Hello and welcome, everyone. My name is Renee Garrett, and I'm your Speech Therapy PD podcast host for Brainstorms, Functional Neurorehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEU. Here are the financial and non-financial disclosures. Melissa Del Pino is the owner of Speech Like Honey Speech Therapy, Inc. She's also affiliated with WordStem and the Dr. Amen University course. Melissa received compensation for this podcast appearance from Speech Therapy PD. Her non-financial disclosure is that she is a member of ASHA and Emboslo. My financial disclosures is that I'm the owner and founder of Brain Bridge Connect, LLC, and as the host of Brainstorms Functional Neurorehab for SLPs and other educational webinars on Speech Therapy PD, I do receive financial compensation. I'm also an adjunct instructor at both James Madison University and Old Dominion University. My non-financial disclosure is that I'm the secretary for the Communication Disorders Foundation of Virginia. Now, without further ado, we welcome our guest, Melissa Del Pino, MS, CCC, SLP, CBIS, who is a dedicated speech-language pathologist, certified brain injury specialist, and Dr. Amen certified brain health trainer. She's the founder of Speech Like Honey Speech Therapy, Inc., a private practice offering speech therapy and consultation services across the lifespan, with a specialized focus on concussion and traumatic brain injury, or TBI. Melissa's passion for brain health and athlete rehabilitation emerged through her clinical journey, where she found her calling in supporting TBI survivors. With a deep understanding of the challenges associated with brain injury and a strong commitment to harnessing neuroplasticity, she works to help individuals regain cognitive function, enhance communication, and optimize overall brain health. Melissa has been invited to speak on numerous topics, including the life participation approach to aphasia, or LPAA, AAC assessment and intervention, creating language-rich environments for late talkers, the role of the SLP in school settings, and the cognitive communication impacts of brain injury. Outside of her professional work, Melissa enjoys camping, gardening, Zumba, and pottery. Melissa, it's so great to see you and welcome.
Thank you. It's great to be here.
So the last few months on the second half of this season, I've been trying to just ask SLPs that are on the podcast and other practicing professionals, what led you to speech language pathology? Because I feel like people are very decisive. Usually they either really know they want to do this or it kind of comes as a surprise. So are you comfortable sharing how you came to be an SLP?
Yeah, of course. So I was introduced to the field of speech pathology around the age of 11, 12 years old. My family member, a cousin of mine, who I was only 9 when he was born, I didn't have any younger siblings, and it was just so exciting to watch him grow and develop and see the milestones. But what I didn't realize at, 10, 11 years old was that he wasn't quite meeting those milestones like he should have been. And so those small whispers in the family then turned into loud calls for action, and his mother was encouraged to seek some support. So he was recommended to go to the regional center where he got assessed and he got a diagnosis, and he began getting early intervention for speech therapy, and he started making so much progress. So whereas before I had a little one where we were only truly able to connect with either snack time or eye contact, we were then able to connect. He was talking to me about Garfield the cat and how much Lightning McQueen is the fastest race car and how fast he was going, and Shrek and all of the favorite movies that he had. And we were able to hear his voice and hear him, share the things that mattered most to him. And it's definitely like lit the fire, I think. So that's how I was introduced to it. And I actually went back and volunteered at the center where he got speech therapy. I'm still really close to them to this day. They kind of led me in the right direction, and here I am. So it's come full circle. He actually designed the logo for Speech Like Honey, and he's just graduated as a graphic designer. So he's
amazing.
Yeah, it's like completely full circle. It's so exciting.
Yeah, that is exciting. That's really cool. I love hearing people's stories too, because it's just, like I said, I learned this morning, Robin Roberts of Good Morning America is a speech undergrad major.
Oh,
I
wow.
had no clue. No clue. She said communications wasn't an option at the college she went to, and so that's what she majored. She said speech. So I'm assuming speech was speech language pathology. So
Yeah.
I thought that was pretty cool.
Yeah, that's so cool.
Yeah. So I know you and I both love talking about TBI, and well, obviously we spent some time on it getting our CBIS, which was not an easy feat. I don't feel like it took some time, some prep, and definitely a commitment to maintaining CEUs related to TBI to maintain it.
Mhm.
So let's start by having you define neuroplasticity and then maybe moving into why it's so essential for TBI recovery.
Sure. And I think in talking about it, I'd like to go over like the history and then
Oh,
the definition
sure.
as well. So, um, TBI, I'm sorry, neuroplasticity initially was between like the 1950s and 1970s, as you know. Um, the concept of it was viewed more as like a developmental phenomenon. So we talk about early intervention in the first 5 years and how important it is to get that, get that intervention in right away. And it was thought that brains cease to develop once we reach a certain age of young adulthood. But now, through like the research of Michael Merzenich and so many other people, we understand that it doesn't end in young adulthood, and neuroplasticity is something that continues on, which is really exciting because if neuroplasticity didn't exist, we truly wouldn't have a job. Like so many people wouldn't have positions. And so it's nice to know that it's something that follows us throughout the lifespan. Um, and when I was diving deeply into neuroplasticity, I reviewed or just thought far back into how far back has this concept been looked into, right? And so even when we're thinking of Ivan Pavlov and the famous experiment of Pavlov's dogs, right? We think about how in that experiment he was studying the brain's ability to be conditioned. And we all should know that experiment, right? We had the stimulus of seeing the food or seeing the owner, and then the dog would start to salivate just by the sight of the owner. And that's what sparked his experiment. And then he began to condition the dogs to, he would ring the bell and then present the food. And then the dog would have the natural response of salivating because they would see the food. And so he did that over and over with intensity and repetition with something that was very motivating. And then the dog's brains were in turn conditioned to hear the bell and then have that response, that natural response. And so it highlighted how experience and changes like the brain's morphology, right? And so it's the experience dependent learning. And so that's exactly what neuroplasticity is. It's the brain's ability to change. I like to look at the word itself, neuroplasticity. So we're looking at the brain, we're looking about how it's moldable. So a moldable brain, and it's our ability to grow new cells, make new connections, strengthen pathways. And anytime we have an experience, something that we experience, that something we think, something we feel, something we do, we're contributing to that change in a positive way or in a negative way. So the way I like to describe it, you mentioned I like to go camping, and out here in California, we have tons of trails and things like that. So imagine a hiking trail that leads to a waterfall. That's a skill, right? And so a storm or a brainstorm comes in, right, and brings heavy rainfall, and that rainfall then ruins that initial trail that was established. And so the safety personnel or the Department of Parks and Rec comes in and they determine that that trail is now deemed unsafe or unusable. So now the trailers or the hikers are having to find a new trail. And so sometimes that takes a while, but through repetition, it's strengthened and then that becomes the newest detour. So that's how I like to describe it to my patients too.
Yeah, and that's so funny because my description is similar. It's if you needed to go to the grocery store and you're coming out of your neighborhood, but there's construction on the road or maybe there was an accident, there's always typically a second way to get there. It's just maybe taking you a different route that's going to take you longer. And maybe you'll have to detour, um, for a good bit of time, depending on like where I live in Virginia, we always have road construction. I swear it's like the thing. It's nuts.
Right.
So a route that might take you 20 minutes is now taking you 30, and you might have to
Mhm.
do that 30-minute route for a year until they figure it out. But you can get there. You just have to go a different route, and it takes you a little bit more time. So I love that analogy.
Yeah. I love analogies in general. I think they make such complex concepts so easy to digest and understand. And
Mhm.
I've used the analogy of a freeway before too, because we have the 405. If you've been on it or if you've heard of it, it's just stay away. And
Mhm.
no, I love using that example as well because it just helps people understand it so much.
Yeah, no, I agree. It's just so interesting when we think about the community. This is something I was talking to someone about earlier, community education and how it continues to be so lacking for this type of information, and how a lot of our patients feel like they're at a dead end.
Mm.
They're not often, even in the hospital, depending on who they're working with, they're not often given um, really solid information about recovery, right?
Mhm.
And how there is a chance that you're going to really have a good regain of skills, right?
Yeah.
And I think that leads into, again, talking about why neuroplasticity is so essential for TBI recovery.
Yeah, definitely. I think a lot of the times when I'm working with someone, they have been, maybe a couple years post their accident, and they have reached a time where they think they've reached a plateau and they think that there is no hope. And neuroplasticity essentially is that hope. It's that reminder that, hey, I know you haven't had enough intervention or you might not feel like you could continue to progress, but there might be some reasons for that, but the good news is that we can still make a detour. And the detours just are dependent on how much we are being intentional about following certain principles.
Yeah. And I think, again, when we start to move into tuning into what our patients and clients truly needs
Hmm.
or truly need, um, we're looking at not only the need, their lifestyle, maybe they were working, maybe they're a parent,
Hmm.
what their other roles are. What are we looking at for that, and tuning in? How important do you feel like that is to look at those things when we're trying to come up with how we reach that neuroplastic outcome?
Right. So whenever I am about to step into a therapy room or a virtual therapy box, I'm always I always want to ask myself, what will I learn about my patient today? And I always try to encourage my clinicians to do the same because it's so important to truly just tune in, learn about them. And we have to start off with neuroplasticity in the forefront of our minds before we address anything. But the biggest key of that, in my opinion, is tuning into our patients because how can we truly make something meaningful without knowing what their day to day is like? So,
Mhm.
in assessment, right, I'm prioritizing the patient reported outcomes. I'm looking at the different prompts that I can use to figure out like what is important to them or what's difficult for them, or I do some motivational interviewing, or like building rapport is more than just checking off a list of things that I need to do in the first meeting. Sometimes building rapport can take a few different sessions, and honestly, it should, right? Because that tells me that we're actually leaning in and tuning in because most of the time our patients don't want to let us know their whole life story right away, right? I'm just another face, I'm just another therapist that they've worked with, or maybe their first therapist and they don't even know why they're working with me. And it's difficult to actually get someone to just kind of let their guard down and share everything about their life with you. So I think tuning in is just so, so important. We're treating a person, not a diagnosis, right? So we want to really understand their day to day. And then when we're thinking of treatment, we want to focus on their needs, and not just because we want it to be functional, but because the brain truly needs it, right? Like that, the functional aspect is because the brain needs it to be functional, which leads us right into the principles of neuroplasticity.
Yeah, I use an example that I've used for years now with my students that I teach, because this happened to me when I was a student. Uh, well, it was something that I watched happen as a student in my off-campus clinicals, and it was just something that even as a student, I realized that this was not best practice,
Mm.
and it was just so disheartening to watch um, this group of long-term care residents come in, and they were doing cognitive therapy, which was
Uh-oh.
everybody gets the worksheet,
Yeah.
you know, in a circle. Um, and anyway, there was a whole lot of problems with it. But the question that someone asked this lady that had been in long term care for a long period of time, and she was in her 90s, but she was, to me, I was like, I don't know why this lady's in cognitive therapy. She's probably sharper than most of us. And the question was, what would you do if your car ran out of oil, or you didn't change the oil in your car, or something along those lines? And she said, well, I don't know. I've never driven and I've never owned a car. Perfectly plausible answer. And they said
Right.
she was incorrect. Yeah. And I saw a lot of that when I was in this facility. And I was like, this isn't, it taught me what I didn't want to do and what my
Mhm.
practice didn't want to look like, because I realized this lady didn't have a TBI. She didn't have a stroke. She didn't have dementia. She didn't have anything.
Right.
It's actually pretty spunky and fun. And
Yeah.
I just wanted to have a cup of coffee or whatever with her. But it taught me when, going into inpatient rehab and working primarily with brain injured patients, was that we don't want to hold them accountable for a skill that wasn't a strong suit prior to their
Mhm.
injury, right? Can you learn a new skill? Well, sure, of course. But if that thing wasn't important to them or wasn't something they were utilizing before, how are we going to hold them accountable now that they've had this traumatic brain injury for this skill? Maybe they also had an underlying condition like ADD or ADHD. They might have been exposed to trauma. And you don't learn, like you said, that's not necessarily going to be in their electronic health record.
Mhm.
It's also not something that people are going to be on day one, like, hey, I had this traumatic event, or, I got blown up in another country because I was a military member, or
Right.
I was a student athlete and I had 6 concussions in high school. People aren't leading with that. We have to dig and get to that,
Yeah.
right? And I think that's probably kind of where, where you were headed on, how we get to that, how we get that rapport building skill set. And you mentioned motivational
Mhm.
interviewing. I call that like informal assessment a lot of the times with my students, because there's really no standardized measure for that, but it's really the chunk of information we truly need.
It truly is.
Yeah.
Yeah.
Yeah, because
'Cause
it helps us serve our patients, but it also helps us design a treatment plan that makes more sense. And that leads into another thing that you mentioned, was the leaning into therapy, because a lot of times our clients are not. And they're like, who is
Right.
this speech lady and why are you here? Or this speech
Yeah.
guy, or whatever it
Exactly.
is. Yeah.
Exactly. And I think, if I'm trying to address something that I think is functional, like, okay, well, we're going to work on setting reminders so we can make sure we pay our bills on time. But my patient says, well, my spouse has always paid our bills. Then that might be functional in my eyes, but it's not functional for them or meaningful. And
Mhm.
that's going to be a building block, right? If I'm not choosing something that is meaningful or has the principle of salience, then I'm not going to be maximizing neuroplasticity as much as I can be if I truly just ask the right questions or ask those open-ended questions, leading questions to help them kind of tell me what's going on in their life. It's far, I think, even asking like, "How was your weekend?" or "What did you do over the weekend?" It's not just, like a buffer to get into the therapy activities, or we're just gonna quickly talk about our weekend, and so that way we can move on and go into our activities. Like, those questions can lead you into what's really difficult for that patient, right? If they're
Mhm.
telling you about a party that they were 2 hours late to because they saw the invitation, but they didn't read the invitation correctly, then that's what you should be addressing, right? Like those are the skills that actually matter. And it's so interesting because, especially when we have clinicians that ask the questions, they're like, okay, I have a whole thing planned. I like to not have anything planned, right? Because then it really challenges you to lean in. Like you have your
Mhm.
goals, of course, but you're challenged to lean in because are you're challenged to understand them a bit more. So I think tuning in is like the strongest skill that you can refine. And as we're working on our patients' neuroplasticity, these are skills that we're also refining and we're also creating this change and molding our own brains too, right? So that's why I'm so obsessed with neuroplasticity because me helping you, I'm helping myself become a better clinician. And the neuroplasticity is happening in both ways, right?
Yeah, because it's allowing you to not only cater to the patient's needs, but you're fostering creativity in your own clinical practice because it again, it takes me a lot back to the world of student clinicians when I was a student clinician and not having a lot of materials, not having a lot of resources to rely on, particularly in the adult setting I was in, and having to kind of like, there's a magazine in the hallway or there's a newspaper. How can I use this with this geriatric patient
Right.
to work on their reading deficits from their aphasia or their speaking with aphasia? Can they read the headline and does that help them, um, talk and
Mhm.
communicate? And I don't know. I'm with you. I just think sometimes having an over planned session doesn't work especially for our TBI patients because
Yeah.
they have sleep deprivation or sleep cycle issues. They have times where maybe they're a little bit agitated or they're having trouble with self-monitoring their behavior.
Mhm.
Maybe they had something happen, like you said, over the weekend. They could have had an unsuccessful social event or an unsuccessful like outing in their community. And we need to be able to say, okay, well, let's talk about that. You went to the grocery store and you didn't take your list. And so you got home and you're missing
Mhm.
90% or 50% or whatever it is of the things that you went to the store for. How can we change that for the next time?
Right, right. And it's an unpopular opinion, and this is something I've had to grow in, but I love it when I have a patient that comes into the session and they're venting or they're upset, right? Like, oh, I used to get so nervous, but I think over time I've started to mold my brain into understanding that this is good, right? Like, you're venting with me and you're like there that means we've established trust. And
Mhm.
and we need that in order for me to truly understand you and understand where are the pockets, where are those areas of need, because the goals are going to always be changing and the goals are going to like we're gonna meet the goals or we're gonna have to refine them, right? And it all boils down to how well you know your patient. And so that's why I'm always encouraging younger clinicians to like really tune in and ask the questions and let them tell you about their life. Let them tell you that if they want to rant about how they are raising chickens because they used to do that back in their home country, let them, because this is going to give you some information. Maybe this is something they're really motivated by. But now,
Yeah.
when they have a book about raising chickens, they can't understand it and they're not very successful in this new hobby that they've picked up since their accident. The hobby's very meaningful for them, right? So we have that salience, and this very specific skill is this reading comprehension. And so we're able to refine what we're working on because we actually leaned in. But had we just tried to brush that off, we really wouldn't be addressing their very specific goals in a very unique way. And that's all we should be doing, right? We should be treating each patient independently instead of having like a blanket approach.
Yeah. Yeah. No, I agree. And again, having worked with this population for a long time now, um, I always go back to, especially my early on IPR days, because the patients there, for whatever reason, really stuck with me. I
Mhm.
had a couple of them, and I've talked about them on the podcast before. I had one young guy who one of his main goals was to be able to make a protein shake. That was
Mhm.
important to him. I had another patient who was actually a LifeNet candidate,
Mhm.
and they came in, they took her off the ventilator, and she started breathing on her own, and no one expected her to do that. And her goal was to be able to make a cake for her daughter for her birthday. So there
Wow.
were things like that that were very, again, it didn't feel like therapy at the beginning, but it was
Mhm.
very therapeutic, because guess what? You can work on following directions, list making, organizational skills of knowing what those ingredients are, knowing what the temperature is that they have to cook this cake at, looking at, and a lot of people say, oh, OT is the one who does the cooking. That wasn't what our focus was. Our focus was
Yeah.
on the cognitive pieces
The cognitive, yeah.
of what we needed to do. How do we prepare, um, for what that task is you need to do? You've got to remember things. You've got to be organized. You have to make, um, a plan, right? And that's all that we're doing. We're working on a lot of executive functions, truly, in tasks like that. And people get, I think their speech language pathologists get this mindset of that's not therapeutic. I don't know why that is. It's like a disconnect. But to me, that's the most therapeutic, because being able to go pick your kids up from school, being able to remember that you need to order your prescription medication so you can pick them up from the pharmacy if it's a refill. All
Yeah.
those things. We do these things, and we get so wrapped up in these high level, what we call high level tasks. We're not realizing the stuff we do every day is high level.
Level. Right.
Why do people pour orange juice in their cereal? Because they're sleep deprived, because they're tired, they are cognitively overloaded. Maybe they've had a traumatic or stressful event and they are distracted. Most people have experienced a thing like that. And so we can take that and work it into our therapeutic practice, and, realize this is similar to this cognitive dysfunction that our patients are experiencing when it comes to TBI. It I don't want to say it simplifies things, but in my mind, it kind of does, because it makes you realize the human piece of what we need to do every day
Yeah.
matters so much more than doing some workbook task that means nothing.
Exactly. Yeah. There are the foundational skills that allow us to function on a day-to-day basis. Right. And so I always try to, when I speak with my patients about this, I want them to talk to me about it because one, it helps me understand their needs a bit more. And then when we're looking at it further, it really just supports our ability to like refine our therapy, right? And make sure that everything is functional for them. Our patients, sometimes I've had so many patients come in and maybe in our first session or a second session, they're telling me that, either they don't know why they're here, or another, which is heartbreaking, is they tell me that I've tried this and I didn't like it or it didn't work. And so I really want to understand why, right? Like, why did it not work for you? Or why was this difficult for you? And what I'm usually hearing is essentially the therapy that was done prior wasn't maximizing neuroplasticity. We didn't have neuroplasticity as like the forefront of our practice, because if we had, we would have made sure it was meaningful. We wouldn't be throwing a workbook in front of them. We would be doing those tasks that are more functional, and we would be tuning in to what's difficult, right? Or their hobbies that they're really interested in, or if they don't have any hobbies and they don't want any hobbies, well, what were you doing prior to your stroke, right? Or prior to your accident. So that way I can figure out, let's try to get you involved again. And that's why I love life participation approach, right? Because we're really leaning in. I want you to get right back into participating like you were able to. I was in a support group for aphasia a few weeks ago, and one of the members was saying that one thing that they wish that they had earlier on in their recovery, um, they wish that their therapist was more intentional about what they needed. And
That's
when I hear
powerful.
that, my mind's like neuroplasticity, like that's exactly where it goes, right? Because that's being intentional. It's being something that's meaningful and functional for you. You're using those specific skills. But then you can't just say, okay, well, I'm intentional about making sure that they can name all of these things correctly, right? That was my intention. But what was their intention? And so I asked her, I said, what was it that you wish they had done? Well, at that time, I needed support groups and I needed to feel like I can get back into getting involved in the daily tasks that my family was doing. They were
Mhm.
less concerned about acquiring those language skills back right away and more concerned about just being able to sit with their family at the dinner table, right? Or be able to attend an event. And so when we really ask the questions, we're able to understand just a bit more so that way we can really refine it and use that multidisciplinary approach. So that way we can say, hey, or interdisciplinary, right? Communicating with the others and say, okay, hey, they want to be able to sit up during this. And we're looking at the whole person.
Yeah. Yeah. And that's, I think that's a perfect segue into how we approach those patients who do have limited buy-in. Because I think, like you said, it goes back to really being more of an active listener, which for most of
Mm,
us didn't get into this profession to be an active listener. We got it
right.
because we like to communicate, right? We want to help other people communicate. So active listening is a learned skill.
Mhm.
Um, and what is your take on that? What do you do with your patients who have limited buy-in?
Yeah. Okay. So I have two main approaches. I have the meet them where they are with I coined these. I call it the meet them where they are or the discipline first, and I'll go over both of them. And so with my meet them where they are approach, I lead with curiosity always, right? I'm asking what's your life like? Why don't you like therapy? If you didn't like therapy, why didn't you like it? What did they do? And I just let them vent because sometimes just listening, right? I'm taking notes, I'm attending, I'm asking clarifying questions, I'm using all these active listening skills, like you mentioned, and I'm really tuning in to understand why, right? Most of the time, they're describing a therapeutic model, like I mentioned, that wasn't prioritizing neuroplasticity or therapists who just didn't listen. And so it's really challenged me to, because I'm a talker, like I can be chatty. And so it's challenged me to just listen and even when I feel like I'm ready to respond or to provide like a reframe that I want them to consider, I just pause and I might ask, what do you mean by that? And so I'm really letting them just fully explain as much as they can. And then I give space, right? I give space for them to vent, to complain, to share their experience. They might be talking about an argument they had with their wife, and someone walking in might say, well, why are you just letting them vent about their wife? But then if we get down to the nitty gritty, we realize that they're having an argument with their wife because their wife says that they're not listening and they're not remembering details of their conversations. So then we might have a skill we're working on active listening or working on a skill like understanding and comprehending what someone's telling you and working memory where we are able to note down things and hold on to information that is said in conversations, right? So without him venting about an argument with his wife, I wouldn't understand that he has that need. And then we have to practice perspective taking, right? Like, what has this journey been like for them? If I'm not able to put myself in their shoes and understand, you know, they've been struggling trying to get support. They've been trying to advocate for the fact that they feel different, right? They've been telling everyone around them that they're not the same. But on the outside, because it's an invisible diagnosis, they look normal to the naked eye, right? So they're very frustrated. And so I have to practice perspective taking in this sense. And that's when I meet them where they are, right? If I'm taking their perspective and understanding they just want to be understood, and they're just frustrated because they think that they're in front of yet another person that doesn't truly understand where they are, what they're struggling with. Then sometimes all we need to do is affirm and say, hey, I understand that this is difficult for you, or I can see how this has been hard. And just sometimes that can just ease the tension, right? And then again, I love using leading questions to kind of get that extra juicy information that I need. So that's where meet them where they are. And then discipline first is it's a strategy, or it's like a my model that I like to use, and I've kind of pulled from different pieces of information, but I really enjoy the book, and I got it because I was using it for one of my patients. This is the Spanish version of it, but the 7 Habits of Highly Effective People, right? And so they talk about establishing habits. You need knowledge, you need skill, and you need desire. So if you have
Mhm.
knowledge and skill but no desire, there's just compliance, but it's usually temporary. If you have skill and desire but no knowledge, it's ineffective. And if you have
Mhm.
knowledge and desire but no skill, then you're frustrated. So we have a lot of patients that are frustrated, a lot of patients that are that are very ineffective at the skills that they're trying to refine. And so what I try to encourage them is that if I can establish a desire, like if I can determine they have the desire to get better, right? Which is meeting them where they are and understanding what's difficult, then I can be the one to help and provide the knowledge and the skills and refine the skills. And so if we establish that importance and the desire, then we can create the habit, and then we can experience a reward. It's like exercise, right? I
Mhm.
have the desire to be healthy. I don't have the knowledge of how to be healthy or how to have a healthy physique, nor do I have the skill, right? But I'm going to create the habit, and I'm going to keep that up. And then once I start creating the habit and I keep it up, I might find a trainer to help me and guide me in the right direction. I might find dietitian or a nutritionist to help me determine exactly what I need to be consuming, so that way I can maximize this health journey that I'm on. Then I start to notice that I'm experiencing the reward. And once I experience that reward, then I find the motivation, and it's self-rewarding. And then I start to do it because I actually like it. And then because I've activated that behavior, I just continue that, and it just keeps going on and on. And if we think of it like we think of exercise, we can understand, or we can help our patients understand that, even if you don't understand, or if you don't have the skills, like you might not have the knowledge of how to do this, and you might not have the skills. I see you're frustrated, but all I need is your desire, and we can do the rest together. Then we just got to create the habits. The habit's going to be really annoying at first. I tell my patients all the time, it's going to be really annoying to hear those timers, or it's going to be really annoying to have that yellow box and right at your door so you can remember, right? You'll see it, and you'll probably feel annoyed first before you feel that it's actually supportive. And then you experience a reward. Wow, you remember that detail from the conversation I had with you, honey. And they're getting that positive feedback from their family, or their bosses are telling them, like, wow, you remember these details from our meeting. I'm so happy. Like, we don't have to, pull you off to the side and ridicule you for not listening in a meeting. And then it's becomes motivating and rewarding. And then we just continue that practice.
Yeah, and one of the books that I like for, kind of understanding more about the brain,
Yeah.
it came out, and I had to look it up because I couldn't remember the name of it. High Octane Brain. I love this book because, it gives some really cool scenarios of patients, and it's more about, like, enhancing your memory and reducing your risk of Alzheimer's, but again,
Okay.
when we're reading it and you're thinking about a lot of the correlations come about for the patients that we treat with Alzheimer's or dementia, but also
Mhm.
our TBI patients. Everything that we're doing neurologically in the brain, like you
Yeah.
mentioned, is we're capitalizing on neuroplasticity. And so looking at the science base of having a high octane brain, they talk about holistic care, whether it's coming from the nutrition, sleep, maintaining some physical activity, all of those things that, we know are strategy based things, but they're also based in science and research over a long period of time. So it's not like we just came up with this on our own.
Mhm.
And I think a lot of, again, a lot of SLPs miss this piece of we can't just treat cognition like it's one little thing, because it's not. It's impacted by people's nutrition. It's impacted by their sleep. It's impacted by their ability to have some sort of physical activity. You know, when you go to a assisted living facility, it's why people are doing chair yoga, right? They're doing bingo in the activity room, and people are like, "Ah, bingo, whatever." But it's, again, it's keeping people's mind active. It's
Mhm.
having them go from place A to place B so that they have a physical movement involved. You know, a lot of it is, again, executive function, planning. You have to have that foresight of what are we doing next?
Mhm.
How do we get to that? And all that can be impacted by those things that happen when they're outside of the therapy room. So, say they were an older patient that had a prior TBI and they went on the activities bus. I worked at assisted living for a little bit of time, and they would go to the grocery store for the people who no longer were driving, or maybe their family wasn't able to go and take them to get groceries. They'd go to the grocery store that was local on the activities bus. Well, guess what? You've got to remember to show up if no one's coming to get you,
Mhm.
because this was ALF, not total, the total dependence section. They'd have to have some sort of money
Mhm.
to pay for the groceries. They had to have some sort of plan, unless they just went in, like, sorry, husbands, but sometimes husbands just go to the store and throw all
Right.
the things,
A list.
not the list. Um, but yeah, there's a lot of things like that where, again, people don't think that that's a therapeutic task, but it's something that you could totally work on. And we do that with our TBI patients. At least I have all the time, is like, okay, if this is the task you want to accomplish. And again, you mentioned working with your multidisciplinary or interdisciplinary team. We did this with, when we were still able to do community outings, we would take our patients to stores like Target, or they'd go to Chick-fil-A and have to order. They'd have to think about what it is they wanted. Physical therapy, and I would often, in OT too, we would work together to make sure, like, physical therapy is working on balance while they're pushing a cart, while they're thinking about what they're doing. And all these tasks are very neuroplastic heavy.
Right.
Um, and they're also, I worked with a PT that was a neuro PT, and we took this patient to Target one time, and she was throwing like Valentine's pillow in the cart, and that wasn't on the list, to see if he noticed when he got to the checkout.
Yeah.
Like, sabotage is what she called it.
Uh-huh.
But all those things are very therapeutic. You know, menu ordering is something that's very important to a lot of people if they like to go out to eat. They don't necessarily want their spouse or their child, adult child, young child, whatever, to order for them. They want to be able to do that. And how do we simplify that so the patient can do it? You know, there's a lot of ways with like script training and things like that, but you've got to get to what the restaurant is.
Right.
What is the restaurant that you love? What's the place you like to go to with, your wife on a Friday night? Or where did you all go as a family on Sunday afternoon? All those sorts of things are very, um, like you said, salient tasks, right? They're things that people really want to be able to get back to doing.
Mhm.
People don't want to know uh, how to sequence a burger. How do you grill a burger? Maybe some people do. I don't
Right.
eat meat, so I'm not doing that. I always say, if you woke me up from a dead sleep or anesthesia in the hospital and you said, "What's today's date?" I'm gonna get that wrong. Probably gonna get that wrong. I
Okay,
just know me. I might
work
get
it
the month
out.
in the year, but the rest of it, probably not so much, because I don't really. I'm gonna cheat and look at the whiteboard or
Right. Use my strategy.
use my strategy.
Exactly. It's so funny because that kind of brings me to the concept of strategies, right? And or just like compensatory strategies. Sometimes I feel like there's like a sense of a war on compensatory strategies, but I'm
Mm-hmm.
curious to know what you think because I feel like in my mind, when I'm teaching a strategy, I'm more than just teaching how effective it could be, but we're also underlyingly working on the metacognitive skill that it takes to know when to apply that strategy at that moment, right?
Mm-hmm.
So we're working on metacognition, which is so cool. I like using a few analogies for that. I don't know where I got them from, so I apologize in advance, but one of the strategies or one of the ways I like to describe metacognition is the bodyguard. So
Mm-hmm.
it's like you have a bodyguard, or maybe I came up with it, who knows? But you have a bodyguard, right? And the bodyguard is in your mind, and the bodyguard is the one that kind of tells you, like, hey, this is when you should do this, or hey, write that down, you're going to forget it later, right? Or hey, check your calendar before you go to bed, right? Or hey, when you walk into the door, put your keys and your glasses and your wallet all in this box. And so the bodyguard is essentially the one that leads you into knowing when to do the strategy. So you learn the strategy, but the bodyguard or your metacognition is what actually gets you to do it. And that's a
Mm-hmm.
skill that you're actually strengthening and growing. Another analogy, I know for sure, I got this one in a book. I think it's Smart to Put Scattered, but it might be a different book because I was reading both at the same time. But it's Simon Says, and I thought it was so neat. So it was a way to teach metacognition to students. And it was, you are Simon, right? So Simon says, we all know the game. Simon says, put it in your hand. Simon says, put them down. Simon says, turn around, right? Well, Simon says, write this down. Simon says, use your planner. Simon says, ask a question because you'd miss those details. And so it was so neat because I taught this to my patient who tells me all the time that, I'm always missing details of a conversation and I could be talking and midway through the conversation, I blank out and I don't know what's going on. But we used that analogy. We talked about it. The next week, he goes, Simon told me to go and get, yeah. And this is so great. I was like dancing in my seat, right? He said, Simon told me to go and get a planner because I was out of town and I forgot my planner, but I knew I needed one. That's a skill, right? We're growing that metacognition because if he hadn't been aware of that need or aware that he needed to cue himself, then he would be functioning in the same way that he always had been. So what do you think about that? Like the
Oh,
concept?
I love it.
Yeah.
I love it. Yeah, I love it because um, I I think again we hear the term metacognition and people hear the word and they're like they don't want to think that they know what it is, but we do. We learned this a long time ago when you went through speech school.
Right.
Um, and I think even when I have undergraduate students who go into different fields, like nursing or teaching or whatever the case may be, SLPAs, for example, they still know what those terms mean. They just, I think, I don't know if it's a lack of confidence or it's a lack of application or maybe a little bit of both because you haven't had a reason to call it that. Right? And so I think, yeah, for sure, it's just like you're thinking about the skill and when you implement it, because if you're not doing that, what's the point of having a strategy? You're not gonna
Right.
use it if you don't know when to use it. And I think that's really our role is more of that piece. You can kinda teach the strategy, but again, if it's someone who never, say, you know, a geriatric patient, for example, and I'm not picking on them at all, but a lot
Mhm.
of our geriatric patients aren't really comfortable with putting a reminder in their phone,
Mhm.
right? They're gonna be a little bit more reliant on having the doctor's office, email them or maybe call them or give them the reminder card that they put on their refrigerator.
Mhm.
Whereas for me, I typically put everything in my calendar in my phone. About 6 months ago, I don't know what happened, and my calendar got erased, and I knew I had a dental appointment coming up, but I didn't know to
Chaos.
call. I had to call, and that was a metacognition type thing, right? I
Yeah.
knew I had it, but I didn't know when it was because it was in my calendar that got erased. So I knew when to use my strategy. And
Right.
it's the same thing for our patients that it's one thing if you teach the strategy, but if it's not a strategy they're going to use,
Mhm.
it's not effective.
Right, right. And I usually like to review metacognition before I even teach strategies because I want you to know how to use your bodyguard or to know when Simon will tell you to do this before
Mhm.
I even tell you what to do, right? Because if
Mhm.
I teach you the strategy, you can forget it the second you log off.
Mhm.
And then it's
Yeah.
the strategy is only as useful as we implement them, right? So, yeah.
Yeah, and I'm thinking about even just, like, the whole comprehensive approach and how that differs from, like, the isolated skills, because I think that's very related. You know, our cognitive communication, emotion, physical,
Mhm.
differs from just those isolated skills. What are
Oh,
your thoughts?
absolutely. Yeah, well, we're engaging the whole person, right? And so when we have the luxury of being able to, collaborate with other members of that interdisciplinary team, that's amazing. We don't always have that ability, but we still should know all of the needs of that one person, right? And so I've had a patient tell me, we're learning about cognitive fatigue. And then they express that during their PT sessions, I don't get to talk to the PT, but during their sessions with the PT, they notice that they're losing 10 spoons by the end of their session. And so where I'm having to now think about, okay, let's figure out how you can manage your cognitive fatigue, use your strategies, use your metacognitive skills to manage your cognitive fatigue. And let's think about how we can do this best when you are in physical therapy, right? And then as you continue to progress in physical therapy, let's see if it's reducing the amount of spoons that that's using. And so it's really a comprehensive approach looking at all of the different areas. And then also, especially when it comes to TBI, it's multifactorial, right? Or there's just so many different things that the patient can experience. And we have to think about, if I'm having you work on your reading or if I'm having you work on comprehension, but you also have a really big sensitivity to light. And that's difficult for you to even focus because the light is so bright. Then we have to look at all of these other areas and things that we can do to reduce that stressor. So that way you can improve your attention because I'm not going to expect you to improve your attention skills if you're also struggling with the fact that the lights are so bright and they're difficult you can't focus, right? So we have to think about all of the different areas. And it all starts with asking the right questions and really
Mhm.
tuning into how am I going to maximize their neuroplasticity?
Yeah, and a lot of times with our, like, especially when I was an outpatient, the TBI patients that would come in, a lot of times they would say, "You're the first person who ever asked me about
Hmm.
lights. You're the first person who ever asked me about background noise or loud sounds. You're the first
Sure.
person who asked me if I was still having headaches." And so, yeah,
Mhm.
I think when you immerse yourself in that space of really learning as a clinician, it's not going to necessarily be inherent to you unless you've been, a family member or someone who's experienced a concussion or a TBI yourself. You're
Mhm.
not going to know. It's not instinctual to know the questions to ask. You're really going to have to immerse yourself in that continuing education piece or mentorship or both to learn the questions to ask because we don't come out of school fresh knowing that, right? We get snippets of courses. We get a lot of information in grad school and in our undergraduate programs. And, we study a lot. We do a lot of work. We do, like, some of us did thesis and other people do capstone projects or whatever they call it at your university. But you
Right.
don't come out and just have this integrated knowledge of particularly with TBI patients, because I've
Right.
had so many, fellow clinicians go, "Oh gosh, I don't like working with TBI patients. It's just so much work." And I'm like, "That's why I love it. It's work, but it's so cool
Yeah.
because I'm like you, I learned so much from these
That's super
patients." And
helpful.
yeah, and I think about all the things that, um, if I'm having a day of, like, brain fog, especially after I had COVID the first time, I'm like, "My god, is this how our patients feel?" Because, oh
Yeah.
my gosh, I feel like a complete I feel like I don't feel like I can function in this space. Like, how do I take this experience and use it so that I can be a better clinician and make sure that I am asking the right questions and I am, uh, being more empathetic and again, you mentioned a couple of times the
Right.
holistic patient, because really that's what we're treating. It's very difficult to treat something in isolation when it comes to cognitive communication.
Hmm.
Uh, so what advice do you have for clinicians or even families or caregivers that are supporting someone with a TBI when you're looking at goals? Do you want to include caregivers in that space?
Yeah, I include caregivers when my patients want me to or when they need me to, right? But I typically won't ask a caregiver away from I never will ask a caregiver away
Yeah.
from a patient, right? I'm always patient first. Sometimes I'm asking them and they're like, Mija, and they're asking their daughter while I'm asking them. And then of course we'll include them in there. But if not, then, I think the biggest thing that we can do is look at them as a whole, right? Kind of piggybacking off of the last topic we were discussing and talking about the comprehensive approach. I really like to pay attention. A lot of what I do is telehealth, and so I don't always have access to their medical records or, let me see what medication they're looking at. But I like to also ask, especially if they're every week they or every session I have with them, they're experiencing a splitting headache. Okay, let's see what you're taking and let's help you prepare for your next appointment, right? And so, really looking at all of these different areas can really support them as a whole. So, I think when we're looking or when we're trying to maximize neuroplasticity as much as we can, we tune in, right? We establish desire because we want to establish that we want to be able to build those habits. And then we have to prioritize the principles. If we are not familiar with the principles of neuroplasticity, get familiar with them. We should have them tattooed on our forearm. Like, this is something that we should really, because this is something that follows us regardless of what population we're working with,
Yeah.
honestly. I knew about neuroplasticity and I knew that we had to prioritize it and I knew that we had to use it and follow the principles in TBI therapy as long as I've been doing TBI therapy, but we also do early intervention in Speech Like Honey. And I remember I was sitting in front of a parent and a little one, and I'm teaching them skills and strategies for language development. And that's when it truly clicked. Like, we're all just out here maximizing neuroplasticity. Like, regardless of who we're working with, that's all we're doing, right? And so we're just creating these learning environments. We're repeating things over and over. We're making it meaningful. Like, if we're thinking about early intervention, we're on the floor, we're making it fun. We're not trying to get them to repeat flashcards. We are making things fun, and we're being very specific and being very meaningful, and we're using these very specific skills because we don't want to lose them, and we're making sure it's complex enough. We're always try to extend and reach the higher goals and refine our goals to make sure we're really pushing through for that, or where that repetition piece. I always talk about practice makes permanent. It doesn't make perfect, because we can practice. Any athlete or anybody can tell you, if I
Yeah.
practice something the wrong way, I'm just gonna keep doing it the wrong way. Anyone who works with children with Arctic, right? And we're
Mm.
practicing this motor plan the incorrect way, it's permanent until we start to maximize neuroplasticity and do some fun activities and switch it up so that way we can have a new motor plan. It all starts in the brain. It's like the coolest computer we have in the universe, and it's in between our skull. So
Mhm.
definitely focus on neuroplasticity is what I would say. And if we're thinking of therapeutic approaches or just different tips, I like using a lot of visual support, a multisensory approach as much as possible. I'm a Canva girly myself, and I'll pull up Canva like if it's a whiteboard. And then that way, if they're telling me they're a welder, I'm pulling up pictures of welding, and then I'm asking them to describe things to me. So that way it's very functional, very, very personalized, and it's a nice way to just make it more meaningful and practice that salience in therapy.
Yeah, and one of the things you mentioned earlier was about intention, and that's something that we use a lot with our Parkinson's patients, particularly those like I'm certified and Speak Out, and I love that program. And they don't pay me or endorse. I'm not,
Mhm.
endorsing anything like that, but I love it because they talk about that principle is that the difference is you have to be intentional to change your vocal volume and the way that you're speaking, but also in your motor movement and that whole piece. So again, I think, anytime we can think about neuroplasticity across different neurological disorders and diseases, it makes more sense because we realize it's a lot smaller. I think some people get really overwhelmed by that whole piece. And when you
Right.
realize that there's so many things that are more interconnected when it comes to those pieces
Mm-hmm.
of the puzzle, I think that just helps so much more. We did have a couple of questions. A couple of them I tried to answer because someone asked about the life. They said life participating approach, but I said, a life participation for aphasia and where to find it.
Mm-hmm.
And then YZ said, what if a patient has no desire for anything? How do you help them establish a desire?
That's a good question. I think understanding or establishing desire has to start with understanding what's difficult, right? If they think that nothing's difficult, then okay, well, why are we here? But typically they're there because something is going on, something is wrong. And so understanding what's difficult can kind of lead you into the conversation, which is it should start as a conversation, lead you into that conversation of it can get better. And I
Mm-hmm.
like to educate on neuroplasticity. I don't know
Uh-huh.
if this is common, but I love teaching my patients about neuroplasticity because sometimes if their desire is like a 5 out of 10, teaching them how amazing the brain is, like you have to be in love with this, right? You have to be in love
Yeah.
with this organ in your body. It's the coolest organ in the universe. And so being able to teach them just how much they can grow and make new connections and grow new cells and strengthen pathways, sometimes that can establish the desire.
Yeah. Yeah, and a lot of times I think one of the ways I explain it for patients is that, um, I've encountered a lot of patients who think that, your heart rules the body, right? When we know that it's the brain. And so
Right.
I'll say to them, your brain is like the computer that tells everybody else what to do. Your heart
Yeah.
isn't going to beat if your brain isn't working
Right.
properly. You're not going to breathe if this function in your brain isn't working properly. If your brain's not able to send the signals down your spinal column to get to your organs, it's not going to work. And when you say that, people are like, huh, yeah, it's a whole different picture, right? They don't again, I think our community I say this all the time, and I'm sure people get sick of it, but our community education is lacking for a lot of things, and TBI and stroke education in particular, I think, are brain basics.
Yeah.
And we have a lot of great colleagues who are doing work. I was, sharing this morning to a colleague that I have another SLP friend that, is going around and she has a private practice, but she's partnering with companies in her locale that, have, like factory type places or places where they have heavy equipment operators who are
Mhm.
at higher risk for brain injuries due to equipment failure or due to, falls, things like that.
Mhm.
And they're not necessarily like geriatric or even like middle-aged adults with a lot of health things, comorbidities. They're people who just are doing their job and they get hurt
Right.
at work. And so she's going to the workplace and educating people about brain health and how to like be mindful of this prior to, um, something bad happening. So I think that's a really great space for a lot of us to be in because we are the people that know other than, we're not saying we're neurologists or physicians, but we are, those of us who spent the time and education on doing like CBIS, for example. That's a lot of work and it's a lot to maintain. And so I think that's a great space to be able to be in,
Mhm.
really, do that education in our communities.
Yeah, I love educating on brain health and just awareness of it. And I think, like you said, we are so uniquely capable of doing that because we know so much about the foundational skills and then speech and language. And if you think about your best moments in life, those foundational skills in speech and language were likely involved, or eating and swallowing, and that's also part of our scope. So we're the best.
We are the best. Melissa, it was so great to have you on, and thank you so much for agreeing to do this. And actually, that's how Melissa and I met, was at a Brain Health Talks. Well, it's pretty cool. So again, we just appreciate you being here and sharing your skills and your knowledge with us and the audience. Thanks again, Melissa. It's great to see you.
Good to see you. Bye.
Take care.